Yeah, we are on. We are live.
Yes, sir. Just now, sir.
Yeah, good evening and welcome to the session on OSCE. And this time we have four faculty from different institutes. We have Dr. Rajeev from All India Institute of Medical Science, Dr. Kuntal from SGPGI, and Dr. Nupur from NIMHANS, and Dr. Bhaskar from AIIMS Jodhpur. And Professor Suresh Nair as an observer for the faculty. We have four students from two from Hyderabad, Dr. Kartik and Dr. Pratik, and we have Dr. Gowtham from Madurai and Dr. Wael from Saudi Arabia. We'll be doing the same similar type of session like last time, and uh, please take a pen and paper, write down, practice to write down, because that is what you will have to do in the exam. So write down legibly, and then when the question answer is presented, check that you have done it right or not. Do a self evaluation. And people who have any doubts, please write in the chat box. At the end of the session, the faculty will clarify your doubts, not in between. So just keep on writing in the chat box or Q&A box. At the end of the session, they will clarify all the doubts, or in between they will answer your doubts also in the chat box only. So with these few words, I'd like to ask Dr. Kuntal Das to start off his first set of questions. Each faculty has 25 marks, and they're allotted 25 minutes.
Thank you, sir. Thank you. This is a great opportunity to be able to be a part of this beautifully designed program. My regards to Professor Nair, my regards to Professor Panigrahi, and my co-faculty members. And I would like to welcome all the candidates here. So, Shriramji, can I share screen now?
Yes, sir.
Okay, is the screen visible?
Yes, you can go to the start.
Okay, then. So we start. I hope the candidates are ready. Pratik, Kartik, Gowtham, and Dr. Wael.
Yes, sir.
Fine then. So here comes the first question to you. A 42-year-old female, she presented to us with headache and vomiting. On neurological examination, she had a light near dissociation, and patient's clinical photograph and her MRI are shown here. Now, you need to answer this question. What is this clinical sign known as, and what are the anatomical substrates involved in this case? And your time is 1 minute for this question. Whenever you are done, you can just indicate to me. Otherwise, I'm going to ask you halfway through if you are done.
Done.
Is everybody done here? Pratik, Kartik, Gowtham, Wael?
Yes, done.
Yes, sir.
So should I move on?
Yes.
Okay. The second question is, identify these two structures which have been marked with an orange arrow here. And you need to also mention the structure that interconnects these two structures. Time allotted is 1 minute. As usual, once you're done, you can just indicate to me. We can save some time here.
Done, sir.
Done. Pratik, Kartik,
Yes, sir.
Gowtham, Wael?
Yes, done.
Fine then. I'll move on to the next question. So to take this tumor out, what are the two common surgical approaches you can think of? And which among them would you choose in this case and why? Time again here is 1 minute.
Yes, done.
Done? All four of you?
Yes, sir. Yes, sir. Done.
Okay, then before I move on to the answer section, let me ask Pratik then. So Pratik, what do you think is the clinical sign here?
The convergent retraction nystagmus.
Anything else you see here? You can see that the forehead is kind of wrinkled, and the patient was attempting to look upwards, and there is inability on her part to do so. So this is the case where there's upward gaze palsy. Along with that, there is retraction convergence reaction. And this syndrome is known as?
Perinote syndrome.
Great. So what do you think is the anatomical substrate involved here?
The tactile plate, the pressure on the tactile plate can cause...
Can you be more specific? What particular structure inside the tactile plate? Fine then, I'll discuss. Coming to the second part, maybe Kartik can answer me. Kartik, yes. What do you see on image A and B?
The image A is showing bilateral internal cerebral veins, and image B is showing straight sinus and the interconnection by vein of Galen.
Great. We move on to the last part. Maybe Gowtham can answer me.
Yes, sir.
Gowtham, what are the two approaches you can think of here?
Sir, in this case, I can think of supracerebellar infratentorial approach or occipital interhemispheric approach, sir. And because the vein of Galen is it is displaced posteriorly and superiorly, I think supracerebellar infratentorial approach would be appropriate for these patients.
Fine then. So, like rightly discussed, this is a case of Perinote syndrome, and the exact reason is compression of the structures that are involved in upward gaze. And the structures are, interstitial nucleus of Cajal, rostral interstitial nucleus of median longitudinal fasciculus, and the nucleus of posterior commissure. So these are known as the centers for upward gaze. And because of compression of this, your patient had a upgaze palsy. The structures you have rightly identified. And among the two approaches that we commonly undertake, although you answered supracerebellar infratentorial approach, which can also be undertaken, but in this particular case, the patient is probably having a meningioma, which is a highly vascular tumor. The size is moderate. The vein is definitely pushed superiorly, but it is shifted on one side. And out of the two approaches, the occipital transcensoral approach gives a wider corridor. So in a tumor like this, which is vascular, veins are intricately draped over it, but on one side. And probably the wiser choice would be to go for an approach which gives you a wider corridor because it is a vascular tumor.
Okay.
Fine. So we go to the next question. This is a 45-year-old male who presented with right upper limb weakness following one road traffic accident around 6 months back. On examination now, there was a weakness of the shoulder abduction and elbow flexion, but his elbow and wrist extension and hand functions are normal, with a mild sensory loss over the deltoid region. Scapular winging and paraspinal atrophy are absent. Now, your first question is, what is your clinical diagnosis here? Time is 1 minute. As usual, I'm going to ask you halfway through if you are done. Read the question carefully. There are various points in it which will help you in making a diagnosis. Are we done here? Pratik?
Yes, sir. Done, sir.
Kartik, Gowtham?
Yes, sir. Done, sir.
Well, fine. Coming to the second question, as it is obvious it is a brachial plexus injury, can you just draw the brachial plexus and locate or mark the site of injury here? Are you done? It has to be just a sketch. You need to mark the site of lesion. Pratik? Kartik, Gowtham? Well?
Just 1 minute, sir.
I've got 10 seconds left. Okay, then we move on to the third part of the question. Suggest a surgical treatment plan for this patient. You know the diagnosis, you know the site of lesion. Now need to plan treatment. Are you done, Pratik? Kartik? Gowtham? Wael? Again, 10 seconds to go. Okay. So let me ask Kartik then. So Kartik, what is your diagnosis here?
It is most probably a brachial plexus upper trunk injury.
Okay. Why do you think so?
Because the rhomboids and serratus anterior are spared. So it is not a preganglionic root injury.
Fine. Why upper trunk?
So, because only partial C5 is involved there, and upper trunk is formed by C5 and C6 roots. Or else it could be a peripheral musculocutaneous nerve injury.
What is the significance of an intact elbow extension here?
C6 is intact here. C7 is.
C7 is intact. C7 indicates elbow extension. Fine.
Yes,
so this is the upper trunk brachial plexus injury, postganglionic. That is why it is trunk. I hope you have drawn the brachial plexus. I'm going to show you in my answer sheet.
Yes.
So this is the site of lesion here, upper trunk area, which has 6 nerves converging over here, C5, C6 roots, then the divisions, the suprascapular nerve, and the nerve to subclavius. This is probably the site of lesion. As rightly pointed out, there are no signs of root damage, and this is a partial injury. And as elbow extension is intact, so C7 root is preserved. The treatment, what was your surgical plan in this patient, Kartik?
I had written only intercostal to musculocutaneous nerve transfer.
See, what you need to consider here is the patient is 45 years old. So age is on the higher side, number one. Number two, the injury is 6 months old. Already 6 months have gone by, and the best time to repair is within 3 months, if not 3 months, 3 to 6 months.
Yes.
So 2 adverse factors are there, age and the timing. Therefore, direct exploration of the plexus would not be a good choice here. Rather, we have to go for distal nerve transfers. So distal nerve transfers are chosen in a patient who has come to you later than 6 months. So that is the answer here. And the choice here would be for shoulder abduction and external rotation. We need to go for dual transfer. Spinal accessory nerve to suprascapular nerve will give you 15 degrees of abduction and some elbow shoulder stability. And long head of triceps branch to axillary. Here it is possible because C7 is preserved. So this is called Sohm-Sack transfer. A combination of these two will give you good shoulder abduction, external rotation. Whereas the classical double overland transfer, wherein a branch of ulnar and branch of median are transferred to the brachialis and bicep branch, is known as a double overland transfer. So this would be the ideal plan out here. Distal nerve transfer considering his age and the time of presentation. So now we move on to the third question. Observe these neurosurgical instruments that you commonly use carefully, and you need to identify these items. And you also need to mention the advantage of having this particular configuration on one of these instruments. You have got 30 seconds to answer this. I hope it's not a very difficult question. Once you're done, we can move on.
Done, sir.
Are we done, Pratik?
Yes, sir. Yes, sir.
Done, sir.
Well, fine then.
Done.
So the second question is, why is this fenestration in this clip for? What is the purpose of this?
Done, sir.
Done.
Done, sir.
We move on to the next question. Now, write down 2 common indications wherein you'd like to place a temporary clip while clipping an aneurysm. Need to mention only 2. Are you done? Pratik? Wael?
Yes, done.
Done, sir.
Gowtham? Kartik?
Done, sir. Done, sir.
Fine.
Done, sir.
Okay. We move on to the last part of the question here, of this particular question. Mention the 2 principles of aneurysm clip application. Done?
Done, sir.
All of you? Gowtham? Kartik?
Yes, sir.
Okay then. So now Gowtham is going to tell me what
sir.
are the instruments that you see
Sir.
here.
The A letter indicates aneurysm clips, sir.
Okay. What
And
kind
the
of clip
instrument
is
is clip applicator, sir. Sir, Yasargil.
this? What kind of clip is this?
Yasargil aneurysm clips, sir.
No, this design has got a particular name to it.
Fenestrated clips, sir.
Okay, so it is a fenestrated right angle
Right
standard
angle.
sized permanent aneurysm clip. Okay,
Okay, sir. Okay,
the
sir.
design is an alpha design here.
Okay, sir.
And this is aneurysm clip applicator.
Yes, sir.
Why is this particular shape
The
here?
bayonet shape is to facilitate our microscope use, sir.
How does it help?
So that the handles will be held away from the view of our hands won't obstruct the field, sir.
Actually, when you are looking down
Yes,
in
sir.
the line of the instrument, if
Yes, sir.
it doesn't have this shape, then it is quite possible that the tip of the instrument won't be seen to you. But
Yes,
if
sir.
there's a
Yes, sir.
bayonet shape, the tip of the instrument can be easily seen despite your line of view being in line with the instrument.
Yes, sir.
And how does this fenestration help?
Sir, when we want to clip an aneurysm that is over the opposite side of our operative view, and we want to protect the parent vessel intact, then we can use this fenestration. We can trap the vessel inside the fenestration so that the flow will be unaffected.
Okay, so basically this is to incorporate the parent artery or an important branch, or rarely a second clip. Many times you may have to apply 2 such clips from different directions.
Yes,
And
sir.
if you use a fenestrated clip, it will allow you to do so by incorporating the clip inside it. So this is
Yes,
how
sir.
it is useful.
Yes,
What
sir.
are the 2 common situations you have seen in your clinical practice wherein your senior surgeon applies a temporary clip?
Yes, sir. Most commonly, when we have intraoperative rupture of aneurysm, then immediately we'll apply a temporary clip proximal to the aneurysm, sir.
Fine. Second situation?
A second situation, when we suspect the aneurysm is going to for the dissection purpose, for dissecting the neck around.
Yes. So
If we
basically
suspect when dissecting it is going to rupture, then we'll apply.
So it is called elective temporary clipping. It
Yes.
leads to a reduction in the turgor inside the aneurysm. The flow inside the aneurysm decreases, so it becomes
Yes,
easy to handle it. So the neck
Yes, sir.
dissection of the perforators can be done with much more safety once you have applied
Yes.
the temporary clip.
Yes, sir.
Now, what are the principles of aneurysm clip application? What have you
Sir,
written?
first one is the complete obliteration of the neck, sir. There should not be any residual neck remaining.
Fine.
And another principle is we have to apply the clip parallel to the parent vessel, sir, so that there won't be any dog ears, formation of any dog ears.
Very good. So most of it we have discussed. As far as the principles of clipping are concerned, now do you see a dotted line here in the neck of the aneurysm?
Yes, sir.
So this is the line which would have been there had there been no aneurysm here. So this is called the closure line. So an aneurysm clip should be on this closure line. Otherwise,
Yes,
you're
sir.
going to leave some neck out here. The
Yes,
second principle you have rightly mentioned is the clip should be parallel or wherever possible. Many times it won't be, but
Yes, sir.
parallel clip application doesn't lead to kink of the parent vessel. This is very important. And
Yes, sir.
thirdly, to ensure that you have taken the aneurysm completely, you need to understand this geometrical principle that whenever you apply clip on the neck becomes flattened and it increases by 1.5 times to its diameter that you have calculated before. So your clip has to be 1.5 times larger than the size of the neck that you have calculated previously. Otherwise, you.
Yes, sir.
With surgery could not be conducted because your senior surgeon in him up for EV. Now, this is the picture you get after you have inserted the scope inside the ventricle. Now, you need to tell me what are the structures A to E that you see here, and where are you going to make the hole? Look carefully. A, B, C, D, E. And where would you make the hole? In the floor of the third ventricle. Please tell me when you are done.
Yes, done.
Done, all of you?
Done, sir.
Fine. So I'm moving on. Now, by choosing ETV over a ventriculoperitoneal shunt, which should have been easier for you, what advantages you obtained here? Give me just a couple of advantages.
Kuntal, 21 minutes over. 20.
Okay, sir. Maybe I'll wrap
Wind
it
up
up.
with this question. Yeah.
Okay.
Can you show
So if you're
the?
done, please let me know.
Can you show the
You're
scan
done?
again, sir?
Sure. No, there is no scan here. There is only intraoperative image.
Yeah,
The patient has a posterior fossa tumor. Patient has a posterior fossa tumor, and you are doing this procedure because you cannot do a definitive surgery because a senior surgeon is not available.
Yes.
You could have gone for a shunt, but you have done ETV. What are the advantages of ETV?
Yeah, I just request that if people ask, do not go back to the scan because in the exam they will not be allowed to see again. It will be projected and gone. That is how they have to practice. They have to be very attentive.
Done, sir.
Am I audible?
Yeah, but we cannot see your slides. Yeah.
Sir, can it be seen now? Sorry for the interruption. So, Wael, can you tell me the structures that you see? A to E?
Yes.
Please enumerate them.
E is E is mammillary body.
Okay.
And A is infundibulum recess.
Fine.
Chiasmatic recess is B. C is tuber scenario. D, I think. Maybe basilar, I don't know. D, pass D.
Okay, so A is the infundibular recess, B is the dorsum celli, C is the premammillary membrane. We are going to make the perforation. D is the basilar artery, the tip of it and the bifurcation, and E, of course, is the mammillary body. So by doing ETB here, the advantage that you get is that you have an opportunity to keep the patient shunt free because by removing the tumor, you're going to establish the CSF flow, and the shunt may not be required at all. And secondly, since ETV is an internal drainage and a slowish drainage compared to VP shunt, what you're going to still have some CSF around the tumor, which is going to make your surgery easier. Otherwise, when there is no CSF around the tumor, dissection could be difficult. So these are the advantages. So I had more questions, but for want of time, probably I'll have to stop here. Manu sir, maybe you can take it on from here.
Thanks, Kuntal. If you have time, we'll go through the rest of the questions that we have.
Yes,
now
sir.
I'll request Rajeev from All India Institute, Delhi to start off his set of questions. Rajeev, can you please share your screen?
Sharing, sir.
Can you stop sharing, Kuntal, your screen?
Yes, sir.
Is my screen visible, sir?
Yeah. Let's go to slideshow.
Is my screen visible?
Yes. Yes.
Can I start?
Yeah, please.
Yeah. First of all, thanks to Dr. Manas sir and NSI and NASS for giving me this opportunity. And thanks to these delegates also. And here is the first question, and it's having 4 parts. The first part is, this is a spotter. You have to answer immediately. First, who is this man? Is it written?
Yes, sir.
Now you have to enumerate his 5 major contributions to neurosurgery. Done? Is it done?
Yes, sir.
Next question is, can you enumerate the most prestigious award he has received in his life? Next question, name the institute where he joined as junior faculty and retired as chairman of the neurosurgery department. These all are rapid fire questions, not much time. Yeah, Kartik, anybody
Yes.
ready?
Done, sir.
You can, if you have done, you can start answering from first question. Who is this man?
This is a picture of Sir Mahmood Ghazi Yassergil.
Very good.
And his contributions were aneurysm clips, the clip applicator, and micro neurosurgical corridors he has invented for cisternal explorations. And he classified craniopharyngiomas and various meningiomas. Sir.
Yeah. Anything else? Okay. The most prestigious award he received?
He was the Neurosurgeon of the Century award, sir.
Okay. And the institute where he worked as faculty? Anybody having any different answers of any of these questions?
So
yeah.
One more contribution, that Leila retractor.
Okay. Anything else? Any difference? Okay. Very good answers. Hello.
Yes, sir.
Yes.
Yeah, he is Professor Mahmoud Ghazi Yassergil, Turkish born. He is a pioneer of many microneurosurgical techniques, especially STMC bypass, terminal approach. He has developed many instruments. He has brought concept of bipolar and a microscope into the neurosurgery arena. And as you told, and his work on vascular aneurysms, aneurysm clips, and all his microsurgical work has been concised into microneurosurgery 6 volumes textbooks, and he is also known as father of modern surgery. Very correctly he pointed out he is a man of the century. This award was given to him in 1999, and he worked in Zurich from 1967 to 1993, and after retiring from Zurich he joined Arkansas Medical Sciences Institute in USA. Very good answer by all of you. Moving to next question. This 50-year-old lady had a head injury for which she underwent decompressive and then later on underwent cranioplasty. Now, since 3 months, this lady has presented with this defect in the skin overlying the area of cranioplasty, and there is persistent pus discharge from this wound. You have to plan her management. How you will
Rajeev, can you click on the timer? Click on the timer, no? So, yeah.
Sorry, sir.
Yeah.
30 seconds for writing the answer. Anybody done with the answer?
Yes, sir.
And moving to the next part, if this patient requires redo cranioplasty, when would you like to do it? This is a spotter. Needs to be answered immediately. You have to answer the time gap. Is there any criteria or any specific number of years or months? Anybody ready with the answer? Yes, Pratik or Dr. Wael? Kartik, anybody ready? You can take some water, Dr. Gowtham.
Sir.
You can drink some water.
Yes, sir. Yes, sir. Sure, sir.
Yeah, we are running out of time. Anybody ready with the answer? Are you able to characterize what we are dealing with? None of you?
This is so this is the osteomyelitis of this autologous.
Yeah, you have to this is the skin defect over the bone flap. This is the incision which has healed well. Okay, this is the skin necrosis overlying the cranioplasty area.
Yes, sir.
And from this area pus was coming.
Yes, sir.
Okay, so you have to suspect bone flap osteomyelitis. And first of all, you have to see what is happening to the bone flap, and is there any collection beneath the bone flap? What is the organism that is contaminated this wound? You have to do CT, you have to do wound swab, you have to check the culture, what antibiotics she can be given to her according to sensitivity report. And once you have started IV antibiotics, then you can plan if CT scan shows evidence of bone flap osteomyelitis, you can remove this bone flap through the same old incision which you used for cranioplasty. And this bone flap also should be sent for culture. And then this defect area margins of the skin should be refreshened and should be closed by Z plasty or V plasty, whatever is convenient to you. If you need, you can ask for a plastic surgery help also in closing this defect. And redo cranioplasty, you can plan only after 6 months of infection-free state. Most of the times, such bone flaps are infected and should be discarded. But sometimes you can clean it, wash it with betadine peroxide or antibiotics, and store it at room temperature in a sterile pack, and can use it as template, but should never be replaced. None of you answered this question. This is not very good. This is a common scenario you will encounter in your practice outside. Moving to the next question. This 5-year-old girl was planned for admission for this neoplasm surgery. However, day before admission night, she collapsed at home and expired. Relative wanted to know why she died, and that's why they asked for autopsy. This is the autopsy findings. First is this is the gross specimen. Then this is, as she was already investigated and planned for, so this is the T2 MRI, and this is the histopath of the excised specimen. First question of this set is why she died suddenly. Can you enumerate the causes of her sudden death? 30 seconds.
Timer should be on.
Anybody ready?
Yes, sir.
Yes, sir.
Next question. Identify and classify this neoplasm. Another 20 seconds for this writing this answer.
Done, sir.
Done, sir.
Next question. Name the surgical approaches which can be used for excising such lesions. You have to just name them.
Done.
Done, sir.
Okay. Who would like to start? Who is ready?
Me. Wael.
Yeah, Dr. Wael, please start with your first answer. Why she died suddenly?
Could be due to obstructive hydrocephalus or herniation or brainstem compression or brainstem ischemia.
Okay. Okay. Any other cause? Sudden death. Sudden death. Okay. Are you ready with the part B of this answer? Part
Yes.
B of this question? Yeah, please tell.
This is a fourth ventricle lesion.
Okay.
Most likely, depending on the histopathology and the MRI finding, medulloblastoma.
Histopathology is already there, doctor.
Yes, depending on
Histopathology. I have already provided you
medulloblastoma.
histopath. Can you make out
Medulloblastoma.
anything from this histopath? Any clues you can pick up from this histopath for characterizing the exact histopathological diagnosis of this lesion?
Yes, there is small blue cells
Yeah.
with pleomorphism and
Okay, blue cell, Postophosa mass, blue
also
cell.
Homerite rosette also is present.
Okay, okay.
Um,
Okay, what are the approaches, surgical approaches you would like to use for this lesion?
Either telovelar approach or transvermian approach.
Okay, very good, very good. Coming to the answers, this patient may have died either because of the raised ICP because of acute hydrocephalus or acute tonsillar herniation compressing the medulla, or the answer which you missed is any vascular event because this was a sudden death and any tumor can bleed. So the tumor with bleeds can be another reason of sudden death. And this lesion you correctly identified. This is a blue cell tumor, and blue cell tumors classically with the HR rosettes. This is a classical picture of medulloblastoma, and approaches you told it very correctly. Now, can you you didn't told us the classification of this tumor. Anybody ready with the classification?
Yes, sir.
Yes, sir.
Yeah, please tell.
The classic according to WHO, there is at WNT, then SSH class 3 and class 4, and according to the histopathology, there is that classic the desmoplastic or nodular medulloblastoma with extensive nodularity and large cell.
Okay, which one is having the worst prognosis?
Sir, class 3 has a worst prognosis, sir.
Class 3 and class 4. Out of these two, class 4. What is the difference between class 3 and class 4? Group 3 and group 4? Okay, we are running out of time. This is the standard class, standard histopathological classification. You have already told it correctly. This is the one which is was given by WHO in 2016 classification. WNT, SSH, non-WNT, non-WSH. That is group 3 and group 4. And how to differentiate between group 3 and group 4 is group 3 will enhance and group 4 will not enhance. Group 3 and group 4 are usually midline. WNT is usually in the CP angle, and SHH is usually hemispheric. Many of you answered it partly correctly. Small improves are required from your side. Okay, we will move to next question. What is IFOF? Can you identify IFOF in this diagram? This is rapid fire, only 10 seconds. Anybody ready with the answer?
Yes, sir.
Yes.
Next question. What deficit is expected if IFOF is damaged? This is also rapid fire, only 10 seconds. Anybody ready? Dr. Gowtham?
Yes, sir.
Anybody ready? Who is ready?
IFOF is inferior fronto-occipital.
Inferior frontal.
Very good. Very good. From where it starts and what are its components? And first of all, you tell me which one is this IFOF? So many arrows are there. Which one can you? Can you identify it?
The green one going from the frontal pole to the occipital pole, sir.
Yeah,
Inferior.
very right. Very good. Very good. Okay. What are the deficits which are expected?
So, difficulty in naming and identification.
Yeah. Can you be more precise? What role it plays in the language processing? Very good.
Inability to identify and name the objects.
IFOF, told the name very correctly. Inferior fronto-occipital fascicular. This is a subcortical pathway connecting from frontal lobe to the occipital lobe, and it plays an important role in semantic language processing. And whenever it is damaged, it leads to semantic aphasias. You must be knowing how to assess a aphasia?
Yes, sir.
And we can tell immediately?
Sir, aphasias, we have components of reading,
Can
writing.
you enumerate those components?
Sir, naming, reading, writing.
No. Start from first. No, you can't start in between.
Fluency, comprehension, naming, reading, and writing, and repetition.
Okay.
So repetitions are preserved in transcortical ones.
Yeah.
The comprehension is lost with other things normal with intact fluency in Broca's.
Can you tell something about anomias? Because this is IFOF is usually related to them. Can you tell something about how we classify anomias and how we assess them?
Anomias.
Very good, Kartik. You are doing well.
Anomias.
Okay. These are the various subcortical pathways which we usually get. We have to do DTI processing on usually preferably 3T MRI, and then these can be identified. This one is the IFOF. You identified very correctly, and this is usually made up of two components: superficial and deep. And in this diagram, I think you can see this brown one is the IFOF. Okay. These are the various components which you have to assess in a patient of aphasia. And coming to anomia, they are usually related with the nouns. And anomias, they are of two types mainly, which we encountered in clinical practice. They are paraphasias or circumlocutions. Paraphasias are further of two types: literal or verbal, or verbal are also called semantic. And this semantic one is the one related with the IFOF. What happens in semantic one? The whole of the word is substituted by the intended word, but the substituted word will be very similar and related semantically with the intended word. Like son will be replaced by daughter, orange will be replaced by apple, or wife will be replaced by husband. But the word will be complete, and you will be able. It will make some sense. However, in literal paraphasias, the part of the word will be replaced. The word will more than 50% of the word will be, however, will still be preserved. Like pipe, he will call pike rather than pipe, or pipe he will call rather than pipe. Okay. And in circumlocutions, the whole of the word will be replaced by something related word. Okay. They will try to identify. They won't be able to say that particular word, but they will put some sentence or some phrase to point out that what they want to communicate. Okay, this semantic paraphasias is very classical for IFOF. You should be this table should be by heart to all of you. This is the article where from where I have picked up this table. You can take it and keep it for your exams. Moving to the next question. This was a very good question, and all of you answered it very well. I congratulate you for that. Coming to the question number 5. Name this part of the instrument. Spotter. Only 10 seconds. Next question. Enumerate the other components of this system. 10 seconds for that. Next question. For what it is used?
Done, sir.
Who is ready? Dr. Kartik, Dr. Pratik, anybody ready?
Yes, sir.
Yeah, you can start answering.
This is a Hudson brace, sir.
Pardon?
Hudson brace, sir.
Yeah, very good.
And other component are perforator and the drill bit, sir.
Okay.
And it's used to make
drill bit is not the right word. Can you be more precise?
Bar.
Bar. Yeah. Very good. For what it is used?
So to make the burr hole, sir.
Okay. What to do with the burr holes?
For craniotomy.
When you want to operate a chronic subdural, you can just that will act as a craniostomy for you to evacuate the chronic subdural, and for multiple burr holes, you can connect together and convert it to a craniotomy.
We are 20 minutes down.
Okay. These are the various perforators. Burrs. Burrs are of two types: spherical and conical burrs, and trifine also is another component. Now, this used to have a complication of plunge, and that's why it has been replaced by automatic releasing cranial perforators like this one, and where they make a very smooth burr hole and leave a small protective bone pad to avoid dural tears. Moving to the next question: identify this instrument and indicate its use. Immediate spotter. Maximum 15 seconds for both.
Not there. Yeah.
Pardon, sir?
This is the last question for you, Rajeev.
Okay, sir.
Done, sir.
Yeah. Who is done? Who is ready?
So this is vertebral body spreader, sir.
Okay, very good.
Used in anterior cervical discectomies and ACD or ACDF surgery.
Okay.
To spread the adjacent vertebra so that we can drill posterior osteophyte, take out PLLs, and also while putting the cages in minor lordosis, sir.
No, not for cages. See, when you will put a cage, you will remove this instrument. You can't put a cage with the instrument. Okay, this is only used for doing good adequate decompression, bony or soft tissue decompression. This will just increase the availability of space for your working. Okay. Like in this case, you can see this disc space is very much collapsed in comparison to the adjacent ones. See, this one is having huge posterior osteophytes. For drilling such sort of posterior osteophytes, this vertebral spreader is used. It is inserted into a disc space after doing anterior part of discectomy, and when you have reached, most of the disc is out, and when you have reached the when you have reached the posterior osteophyte and you want to drill it, or you want to remove PLL for decompressing the thecal sac, at that time you have to use it. Once the decompression is done completely, then you have to remove it, and then you can place the cage. You can't place the cage with this in situ. Okay.
Yes, sir.
So my question 6 is over. Should I proceed or?
Yeah. No. We'll do it if you have time.
Okay, sir. No issue. Thank you.
I'll request. Thank you, Rajeev.
Thank you
You've
so
done
much,
very well. And now I'll request Dr. Bhaskar to Bhaskar is an additional professor at Jodhpur AIIMS, and he'll be now asking his sets of questions. Bhaskar, please share your screen.
Dr. Rajeev, you will have to exit.
You have to stop sharing.
Sir, you can start. You can start. Okay. It will come.
Is this? Can you all see my screen?
Yes. Not yet,
yes,
sir.
Not yet.
Yeah, okay. Good evening to all. So I'll just start off with 3 scenarios. There'll be questions where you can just write down the answers. So there'll be more of a theoretical, which will help you in your practice also. And the few clinical ones we'll definitely discuss. Yeah, okay. So
can you see the slide? I can see his. Okay, now I can see.
Yeah. So this is a 15-year-old girl who had progressive visual deterioration in both eyes for last 9 months, with a recent 1-month bifrontal early morning headache that is partially relieved by vomiting. She also complains of increased thirst and nocturia, and she has a short stature as compared to her siblings. Weight is 40 kgs, heart rate is 70. She has absence of secondary sexual characters. She has no vision in her left eye. Right eye vision is also poor, and bilateral pale optic discs, and rest of the neurological examination is unremarkable. So this is the representative NC-CT of the head, shows one coronal, sagittal, and axial sections. And so please write down your differential diagnosis. Are we done?
Yes.
Can I move to the next one?
Yes.
Yes, please.
Okay, thank you. So what endocrinological parameters would you be assessing her before intervening? Just enumerate the ones which you would order. Are we done?
Yes.
Okay, and diabetes insipidus, diagnostic criteria. Are we done? So can I start discussing the answers? Dr. Kartik, Dr. Wael,
Yes.
can I proceed?
Yes.
Okay. So in the differential diagnosis, I hope, sorry, the first two you should have written down. 9-year-old girl with solid cystic mass, supracellular.
Bhaskar, you ask questions to them, they will answer.
Okay.
And then only you tell these answers. Okay.
Okay. So I think the first one was a giveaway. So anyway, I'll leave it at that. So,
Okay.
so the craniopharyngioma, pituitary, and if the discussion starts, the other ones which I have mentioned in small, you can mention, but there will always be lots of negatives for these differential diagnoses as compared to the ones on top. So you should be able to discuss it out when it comes to an exam part. So can anybody start off with the second question? What endocrinological investigations would you be ordering? Dr. Kartik?
I would like to work up for the pituitary hormone, sir, including.
Can you name what all will you order?
Yes. I'll ask for early morning 8 times serum cortisol, then TSH and pre-T4. Prolactin, I would like to assess the serum prolactin diluted, and then gonadotropin, sir, GnRH, along with peripheral estrogen and testosterone.
Okay. Yeah, you are right, but just a few corrections. So a cortisol AM and PM sample, you should always order a free T3, T4 and TSH. Prolactin, you are absolutely right. Growth hormone, because that is very important in the long-term endocrinological management of such children, irrespective of what we do and what we are not able to do. And as you correctly mentioned, the FSH and LH. Diabetes insipidus diagnostic criteria, Dr. Gowtham, if you can start.
Yes, sir. Urine osmolality should be less than 300 milliosmoles. Sir.
Okay.
And plasma osmolality is usually more than 300.
Yeah.
And sorry, sir, I can't remember after that. Sir.
Yeah. Anyone else? Dr. Wael, would you like to pitch in?
Decrease in urine osmolarity and decrease in specific gravity.
Okay.
Polyuria.
Yeah, correct. Absolutely right. So So first and foremost is there has to be a setting where diabetes insipidus can happen, like a cellular surgery or a head injury. So first and foremost is please don't forget polyuria has to be there. So you can have various criteria like I have mentioned. So that should be there. Then there should be serum hyperosmolarity, that the sodium should be more than 146. So you can all remember the formula for calculating that also. And urine specific gravity should be low. It's a wide range, but generally 1.010, you will find many texts 005. If you can measure serum urine osmolarity, beg your pardon, and plasma osmolarity has to be more than 300, and the patient should have a normal renal and a thyroid function. So these are very important. So these not just theoretical, it's a practical aspect also. So then in your exam, you might be shown slides like this is what the child's slide was. This is a low power magnification of a craniopharyngioma. And you might be asked to identify the cells and why it is a craniopharyngioma, if at all. So this would be a high power. And then in a practical, you might be asked to discuss what is the difference between a papillary and an adamantinomatous craniopharyngioma. Would anybody like to start off? Dr. Pratik, if I may.
The papillary mostly occurs in the children, while the adamantinomas in the adult is
just remember it the other way around.
okay.
Yeah, adamantinomatous is not adult. Yeah, any other?
Yes, me.
Adamantinomas is more common variant commonly seen in children, can have cyst and also calcification.
Yeah.
Papillary is seen in adult, usually cysts are rare and calcification is also rare. Adamantinomas recently have been shown to have WNT and CTNB11 mutations there, sir. But papillary doesn't show any of these such mutations.
Yeah, papillary has been shown to have a BRAF mutation. Prognosis and management wise also both have a difference. It's more challenging to excise an adamantinomatous because there are finger-like projections which go into the surrounding parenchyma.
Yes.
That can be a discussion for your case. Okay. So all of you done well. So we'll go on to the next. So this is a 30-year-old lady who has left-sided hearing loss since 2 years with no associated tinnitus and has developed recent onset gaits and steadiness. And her examination reveals she has papilledema, nystagmus, grade 2 7th nerve palsy, left ear sensorineural hearing loss, bilateral cerebellar signs with brisk reflexes, and an outgoing plantar, and a sensory system is okay.
Yes.
So I want you to write the tuning fork test, which would suggest that she has a left-sided sensorineural hearing loss. Can I move to the next? As and when you are all done, just let me know.
Done, sir.
Done, sir.
So I'll go to the next one then. What are the subtle facial nerve signs that you look for in a patient who doesn't have obvious facial nerve palsy? When you are done, please let me know.
Done, sir.
Done, sir.
Done?
Yes, sir.
Okay, great. And what is the House-Brackman grading for facial nerve palsy? You can just briefly write the grades. No need not go into the detail. Or kind of a theoretical question, but it also has practical implications. When you are done, you please let me know. Sorry, I didn't start the timer. Are we done? I think we can start discussing the answers. Shall we? Okay. Dr. Gowtham.
Yes, sir.
Yeah. Would you start off with the first? What tuning fork tests?
Yes, sir. I will do Rennie's and Weber's test, sir, initially.
Okay.
Rennie's test will show air conduction will be more than bone conduction on both sides in case of sensory neural hearing loss. And Weber's will be lateralizing to the right side, sir, in case of left sensory neural hearing loss.
Okay. How would Rennie's show air better than bone if the patient has a sensory neural hearing loss on the left side? How do you explain that?
Because the conduction system is normal. The
conduction system is normal, but the impulse has to go through the nerve. That
yes,
is
sir.
functioning.
Yes, sir. That is impaired, sir.
Yeah. So anybody else would like to help him out? Dr. Kartik?
That will be a false positive release because through the osseous transmission, it will go to the opposite side, and from that there will perceive. So the same side will be false positive release in severely dead ear or severe sensory neural hearing loss.
Yeah. So to just make it very clear, Rennie's would be air conduction would be better than bone on the right. But on the left, you can have a bone better than air because the bone conduction would be routed through the right ear, not actually through the left. So that would be a false negative. So you would have to mask the right ear to get this corrected. So please understand this. This is very important. And Weber's, as you correctly said, will be lateralized to the right ear. And when you do a Schwabach and a conduction, they would be reduced on the left as compared to the examiner. Is it clear?
Yes, sir.
Okay, great. So what are the subtle facial nerve paresis signs that you know of, Dr. Yeah.
Sir? Yes, sir. So on gross observation, there will be decreased frequency of eye closure, sir, on the palsy side. We ask the patient to close the eyes with full force, and if we try to palpate the vibration in the eyelids, it will be less on the palsy side, sir.
Yeah, great. Any other that you can think of?
Oh, corneal reflex.
Sorry?
Corneal reflex.
No, that would not be constituted as a sign of a subtle facial nerve paresis.
Sir, may I answer?
Yeah, Dr. Kartik, yeah.
No, sir. Sir, there will be reduced spontaneous blink. Another one, what Gowtham said, is Bargera-Wartenberg sign. Other one is the Babinski sign of platysma, in which we ask to contract the platysma, so ipsilateral platysmal folds will not be seen well, and absence of crow feet on the lateral aspect, lateral canthus, on tight closure.
Yeah, great. So these are not all the list, but that there would be decreased forehead creases on the affected side, and as you rightly said, there will be a lid lag and a decreased blink rate. And when the patient closes his or her eyes tight shut, the eyelashes won't be as buried as in the normal side, and you might be able to open it in spite of the patient trying to forcefully close it shut. And the nasolabial fold asymmetry, you might be able to notice it while you are having a conversation with the patient. And as you rightly said, if you palpate on the eye, the affected eye, you would notice the difference. And there is one test where you make the patient's head away from the table in the supine position, slightly hang it back, and ask them to close the eye against gravity. You might notice a difference between the affected and the normal side. So House-Brackman, I think it's more of a theoretical question. So you all must have got it right. So it's graded from 1 to 6. So there are sub definitions of how you make out, but most important thing to remember is 1 is normal, 6 is complete paralysis, and then 2 to 5, it's a grading. So which you compare pre-op and post-op, and then you make out what you do with it. So this is representative images of the same patient. So might be shown MR images. So this is a representative T1, T2 and contrast image. And then you might be asked, are MR and CT both need to be done or one is enough? And what advantages would a CT offer in such a patient for management? This is not for marks. So Dr. Pratik, can you just tell what advantages would you have to get a CT done to manage such a patient?
So we can see the high-lying jugular bulb in that CT better. Plus, so we can see that porosity of the mastoid region where we.
Correct. Any other?
And also internal auditory canal widening.
Yeah, correct. Any other that you both other two?
Any calcifications, if anything is there, sir.
Yeah, right. Anything
like
else?
Vitreous pneumatization also we can see.
Yeah. So you got quite a few of them right. So you would need to know the aeration mastoids, any emissary vein, sutural variations, internal auditory meatus, the thickness of the bone, and a high jugular bulb amongst other factors that you would get better information on a CT as compared to an MR. So both are complementary. It's not that you can manage with just one. So a third scenario, a 60-year-old man has progressive spastic paraparesis with sensory loss over both lower limbs, reaching till the abdomen since 6 months, and onset bladder dysfunction for a month. He's a chronic smoker, no other comorbidities. So patient reveals positive findings are upper limbs are normal, lower limbs power is 0/5 with spasticity, superficial abdominal reflexes all are absent, loss of all sensory modalities till the umbilicus, and no spinal tenderness or deformity. 1. What is the level of the lesion in the spine? Your reasons. We'll have to hurry up a little because I have only 27 seconds of my time left. So we'll try to at least finish this. Rest is just rapid fire. So can I move to the next question?
Yes.
So this is more of theory and with practical implications. MRC grading of muscle power. You should be able to write it down. This should be a very easy one for all of you. Done?
Yes, sir.
Okay, great. And modified Ashworth scale for spasticity. So as and when you are ready to discuss the first one, please let me know.
Put it on the time.
Yeah. So I think we'll start off with the discussion so that lost in this lack of time. So I think the second and third you can So, Dr. Kartik, if I may, what is the level lesion in the spine?
The sensory level will be D10, sir. And the motor highest level it's like about D8, sir, because abdominal reflex is lost in all here.
Okay.
The spinal inflection should be about D8 and sensory is D10 till umbilicus, you have said, sir, abnormality.
Okay.
So I would like to keep the lesion somewhere at D8, sir.
Okay. Dr. Wael, your thoughts?
D10 level.
Okay. Other two also you agree?
D8, sir.
D8, sir.
D8?
Yes,
Okay.
sir.
You are all in for a surprise. So based on motor, you would to localize it between below T1 and above L1 because upper
L1,
limbs, lower limbs. So reflex level, it has to be above T6 because all superficial abdominal reflexes are absent. You are right, till umbilicus, that is D10. If you still want to know it further, you can do what is called the autonomic reflex, which I was also recently taught by my teacher 2 days back. So that is what you stimulate the skin and then you find what is SKARV, skin axon reflex vasodilatation. So you can theoretically, practically make out whether the lesion is higher up. So by this, your lesion has to be between T1 and T6. That would be a spinal cord level. And as we all know that the spinal cord and the vertebral level, they don't go in sync. So as you add the number based on the vertebral level, you can subtract and then you would arrive at the level. So it has to be T1 and T6 in the cord. But and anyway, I would just go to that. And muscle power, I think it's quite simple. Use it in your practice also. And same goes with the Ashworth scale. In case any of you is not aware, there is one modified Ashworth scale also. It was not enough. They have added one more. So how the image looked like in this patient. So you can make out a lesion at D. So clinically and radiologically, there was a correlation. Fair enough?
Yes.
Yeah.
And so if you have, then you might be asked to discuss how do you exactly make out an intramedullary from an extramedullary lesion on an MR. What is the cord signal? What would the CSF signal be? So we can have this at the end of the class because I think I'm out of time. So I'll just go to some rapid. This will all be some 5 seconds for you to just write what it is. Okay. Just write the name of the instrument that you are seeing.
Yes, sir.
Done?
Yes.
Bhaskar, this will be our last question.
Yeah. So there's just one more image. That's all. I'm done. Yes. And the next one you've already answered, so you can't get any marks for writing what this is again. Okay, I hope all of you have got it right. We'll not discuss because I am already out of time. So these are the answers. The first one is a Mayfield Keys skull clamp, XL bone ronger, brain cannula, tumor forceps. And the instruments, please remember, you might be just asked to name and then the discussion might go on to anything which might include sterilization of how you do it, what do you use, and things will go on from there on. So there's no way that you will be only able to identify. So any doubts, you can please feel free to clarify once Dr. Nupur also finishes. So and best of luck in your exams. Thanks a lot.
Yeah, all your doubts, please write in the chat box or Q&A box so that after Dr. Nupur finishes, the faculty will answer the question. And please write the name to whom are you addressing the question. Okay. Thank you, Dr. Bhaskar. And now I request Dr. Nupur to present his sets of questions. Dr. Bhaskar, please just sharing.
Doing that.
Nupur, you are online?
Yes, yes, sir. So is it visible?
Yeah, yes. We'll go to slideshow.
Yes. Yeah, so sincerely thank Dr. Manas and Dr. Nair for giving me this opportunity. It's always a pleasure to interact with both of them. And also thank the NSI for this the initiative. It's a very good initiative. So starting with the questions right away and wishing all of you good luck. Most of the questions have only one word or maximum sentence answer. So we'll start right now. So see the following image and answer the following questions. So you see an image of a STMC anastomosis on your left side. That is a microscopic view. On the right side, there is an image. So all the questions will be directed on that image. So what is the name of the dye used in this? Pratik, quick.
Sir, ICG, sir.
Very good. So ICG stands for?
Indocyanine green, sir.
Great. So the answer is indocyanine green. And now the question goes to Gowtham. What is the mechanism by which this image is generated?
Sir, this works under higher infrared spectrum, sir. So indocyanine green actually absorbs and emits the infrared spectrum.
So what is infrared spectrum? Can you tell the wavelength?
It's around 730, sir.
And so what happens? How do you produce that infrared light?
First of all, the microscope, when we change to indocyanine green mode, the light emission will be very high, sir. So the energy it gets absorbed and it is emitted in infrared wavelength, sir. So that will be captured by the ICG cameras.
I think you're partly correct. Okay, how is the dye metabolized, Kartik? How does dye metabolize?
This dye binds to plasma proteins, sir. So thus it remains in circulation and then goes to liver for metabolism.
Okay, how is it metabolized or not metabolized?
Second pass metabolism.
Okay, let's go to the next question. Dr. Wael, what are the side effects and their frequency?
No, I don't know.
Is it a safe drug? Is it not a very safe drug?
I'm not sure.
Not sure. No problem. So the answer is that there are no known metabolites. It is excreted almost unchanged by the liver. It is very safe, has only significant side effects, only some severe anaphylactic shock that can occur with any drug. That's 0.05%, and 0.2% can have 0.2%. In fact, within 8 minutes, this dye is in the liver. So I have given you a clue to the next question, in fact. So the next question is that what is the half-life of this drug? And I address this question, Dr. Pratik.
8 minutes, sir.
8 minutes, it will be in the liver. So divide by 2.
4 minutes.
4 minutes. Okay. So Kartik.
Yes.
What is the dosage of this drug? It's very important. You should know all these things. Tomorrow when you go in practice, you may not have a very experienced anesthetist with you.
Dosage not sure, sir.
Okay, no problem. Gowtham, and this is very important in vascular surgery. After how many minutes can you administer it again? Once you are given, after how much time will you wait to get it administered again?
Sorry, not sure, sir.
No problem. So this is the answers. The half-life is 4 minutes. The dose is 0.2 to 0.5 mg per kg. You can go up to a maximum of 5 mg per kg. It's a very, as we already discussed, a very safe drug. and can be repeated after 5 to 10 minutes till you reach the maximum dosage of 5 milligram per kg. So just to give you a very brief history, this drug was introduced in neurosurgery in 2003 by a European group headed by Dr. Gaab. And whereas it has been under use in eye, especially in eye for doing retinal angiography and all those things, fluorescein angiography for since 1950s. So now we come to the second set of questions now, and I begin with Dr. Wael, that the usual clips that we use are the Yasargil or the Sugita clips. Among these 4 designs, A, B, C, D, which is the Yasargil or Sugita aneurysm clip design, and what is it called? If you had been paying attention, Dr. Kuntal had addressed this question. Dr. Wael, please.
D.
Pardon?
D.
C.
D.
Your answer is, pardon?
D, doctor. D.
D. Yeah, so the answer is D, and it's called an alpha clip design. As you can see, it slightly mimics the Greek letter alpha. So this is what the almost all modern clips use this design. Now, my question to Dr. Pratik, what is the metal or alloy used to make these modern clips and why? Pratik.
Sir, it use titanium, sir.
Excellent. And why?
That is MR compatible. Titanium is MR compatible.
Very good, very good. Medical grade titanium, it is lightweight, strong, and minimal interference with CT and MRI. And I go to Dr. Kartik now, and all of you can think about this for 2 minutes or 1 minute. What is the difference between temporary and permanent clips? I'll just give you 2 clues. It's not about the color. Color is just for identification, and it's not about these serrations. Both of them have serrations, as you can see. So what is the difference between temporary and permanent clip?
The main difference is pressure, sir. Like
just let others also think over it. Yeah, Kartik, you can go ahead with the answer now.
Yes, sir. The temporary clips of Yasargil variety has around 120 to 130 grams of pressure, sir, and the permanent produces 150 grams of pressure.
120 and 150, it's little less, no difference?
110 to 130 for temporary and 150 for permanent in Yasargil variety.
Okay. So yeah, so you have hit the right tone. The difference is in the closing pressure.
Yes, sir.
Okay, exactly. So a temporary clip will have lesser closing pressure. And it is 90 to 110 grams if you talk about grams. And in the temporary clip, and around 180 grams, maximum is 180 grams, somewhere around 170, almost double.
Yes, sir.
In the permanent clip. Okay, when it comes to Newton, I try to remember is a 1 and 1.5 Newton. One is a temporary clip pressure, 1 Newton, and the permanent clip pressure is 1.5. Okay, 1.5 you can remember, but this is the main pressure. This is the main difference. Now, this is a clip, and I have put 2 arrows here. One is close to the pivot or the fulcrum, and one is near the tip. And the question is, what is the difference in the closing pressure at the tip and close to the pivot fulcrum? And this, you can all think about it, but I will address this question to Dr. Gowtham. Take some time. Think about it. Tell me, Gowtham, if you're ready, huh?
Yes, sir. Sir, there is no difference in pressure, sir, because of the design.
Okay, so that's a wrong answer. So always, if you remember your basic high school physics, this is a type 1 lever where the effort is this side and the load is this side, and here is your fulcrum. Okay, so your mechanical advantage is always equal to effort arm divided by load arm, isn't it? So if you decrease the load arm by taking your point of load here, your mechanical advantage is more, isn't it? If you take your load arm longer by load arm here, your mechanical advantage will be less or more?
Less, sir.
Less. So always the closing pressure is less towards the tip and high towards the close to the pivot, and that is why sometimes in the big and complex aneurysms you need a booster clip. You need a booster clip for the tip area.
Okay. Okay. Yes.
So remember that it's a clip is also a type 1 lever. Okay.
Okay.
So closing pressure is lowest at the tip and maximum at the close to the pivot. Now, again, Dr. Kuntal had already discussed this. This is just to see whether you remember anything or not. The diameter of a neck of aneurysm is 4 millimeters. And this is for Dr. Wael. Will a 5 millimeter straight clip provide optimum clipping?
No.
Very good. And why?
It usually have to be at least more than 2 millimeters than the neck, the diameter of the neck.
Very good. So which clip in the beginning only when you come to the OT, which clip, minimum clip, you will see that it is there with you or not?
7 millimeter.
Pardon? 7.
Yes.
Yes. Okay, good. So I'll just revise. It's a minimum 6 millimeter clip. You should be there in OT because 1.5 times the diameter. So when the neck of aneurysm is squeezed shut by the clip plates, the diameter of the neck increases by about 50%. Hence, the clip plates should be much longer, at least 1.5 times the neck diameter. So with this, we finish the second set of questions and we go to the third set now. Dr. Pratik, just identify the specimen in this specimen. The one tumor is shown in this specimen. Quick spotter.
So this is a cut section of the brain.
Diagnosis.
Sir, ependymoma.
No. You can see the fourth ventricle is quite clear. Can you see this?
Yes, sir.
You're right. It's something in the posterior fossa. You're close.
The diffuse pontine glioma, sir.
Excellent. Excellent. Very good. Pratik, good. So, diffuse intrinsic pontine glioma, it's called DIPG. And the answer, next question to Kartik. What is the usual age of diagnosis of DIPGs?
Usually in the first decade, sir, like
very
8
good.
to 10 years.
Below 5? Very good, very good. So the answer is correct, 6 to 9 years. And next question goes to Gowtham. What is the median overall survival with or without treatment of DIPG patients?
6 months, sir.
6 months is a little less. Dr. Wael?
14 months.
14.
Yes. 1/4.
Okay. So yeah. So you have you have extended the range on either side a little bit. So it's 8 to 12 months. Okay. Slightly shorter than what usually GBM is. And the interesting thing is that less than 1% of these children are alive at the end of 5 years. One of the toughest neoplasm to treat. Now, the question goes to Dr. Wael again. What is the most common mutation seen in these tumors?
I'm not sure.
Okay, Pratik.
No, sir.
Pratik, Kartik.
So H3K27 mutation for gliomas.
Very good, very good. So the next question is for Pratik. Once you know that the H3K27 mutation is there, that's the correct answer. Okay, before going to the further pathology, Pratik, what is the incidence of hydrocephalus in DIPGs?
No, sir.
Okay, so it's not very high as what we will think. It is actually less than 10%. Okay, that's the answer. Gowtham, what was the change in 2016 classification with regards to DIPGs?
Sir, mitochondrial molecular markers, sir.
So what was the change? How was it different from the previous classification?
Sorry, sir.
No problem.
The terminology has changed, sir.
Yeah. Okay. Dr. Wael, would you like to answer that?
No, sorry, sir.
No problem. Pratik?
No, sir.
Kartik?
Sir, although histologically these are mostly grade 2 BRAF positive, but because of H3K27M mutation, they have been separated into a different group because of lower prognosis, like lower overall survival.
Which group now it is under now?
Midline diffuse glioma.
Very good, very good. It's some. So they're now into the category of diffuse midline gliomas, which also includes thalamic tumors, other midline tumors, sometimes rarely spinal cord tumors. Okay, diffuse midline, they are characterized by that mutation S3K27. Okay, so this you may get a long case also of midline a brainstem glioma. Few of you may, I think one out of 5 may get a long case of a brainstem glioma. Now we come to the fourth set of questions, and it's a 16-year-old boy with a recurrent problem. All of you have to see the MRI and then tell me your diagnosis. Remember, patient is having some recurrent problem and it's only a 16-year-old boy. I start Pratik. See it. Pratik, if you're ready, you can tell the answer. If you want time, you can take. Pratik, you want to answer or I'll pass?
Pass.
Okay. Kartik?
These are multiple T2 hyperintense lesion in the right thalamus and cerebellar hemisphere left side.
Very good. So what it can be? Some recurrent thing.
16-year-old, so most probably some infective pathology.
Infection, recurrent.
Infective pathology.
I would have shown you contrast scan, no?
Yes.
Okay, Gowtham?
Sir, don't know, sir.
Dr. Wael?
No, pass, sir.
Okay, so these are multiple ischemic strokes. A 16-year-old boy is having multiple ischemic strokes in the posterior circulation. Okay. So I know it's more of a neurological thing, but let's come to neurosurgical question. So multiple ischemic strokes in the posterior circulation is the answer. Now, can you think of a neurosurgical pathology which can produce this kind of a clinical picture? And I will give you a clue that one of these episodes occurred in a barber shop while getting a massage. So, Dr. Kartik.
So
Kartik.
This is some like bow hunter stroke, sir, involving the posterior circulation.
Yes, and that is because of some problem where?
In craniovertebral junction, sir,
Or
upper cervical spine.
Yes, yes. So that's correct. And there is some instability at the CV junction. Okay, that is the answer. And let's go to the next question now. And Gowtham,
Yes,
give your diagnosis on the following dynamic X-rays. Think about it. Don't be in a hurry. This is a flexion, this is extension. Tell me when you are ready. Gowtham, you are ready?
So sorry, sir, I'm unable to make out. Sir.
No problem. Dr. Wael?
Atlantoaxial subluxation.
Pardon?
Atlantoaxial subluxation.
Yes, very good. Do you think it's normal or it is a little more than normal?
It's more than normal.
Exactly, very good. So we'll go to the answer. It's a reducible hypermobile AAD, probably with an os orantoid. Okay, so next, Pratik, this patient underwent a DSA because this presented with a vascular stroke, has undergone a DSA and also a reconstructed CT angio image. Okay, so what is the anomaly that we see? So this is the, on the left side the DSA and the right side is the reconstructed CT angio. Okay, so this I'm showing you only the right vertebral. Since this is prone, this is the right side. The left side is totally blocked because of the disease. Okay, now what vertebral artery anomaly are you seeing this in this CT angio, 3D reconstructed, and this DSA? I think I addressed the question to Pratik. Pratik, did I ask you this question or?
Sir, it is directly going over to that.
Just to orient you, this is your occiput, this is your C1, this is your C2, C3, and the artery is coming out of C2 as it should. And then after that, there's something abnormality.
Yes, sir. That is not going over that C1 arch. That is going directly between the C1 and C2, sir.
Exactly. And so this is the C1, C2 joint where you would like to do all your manipulations, and it is right behind it. So it is it's a dangerous location or not a dangerous location? Yes, sir. It's a dangerous location. Okay. So
we are 20 minutes down.
Yes. So this is the persistent first intersegmental artery which goes below the C1. So Gowtham, you have to see the X-ray, and this is a postoperative X-ray, and you tell us what is the mode of fixation seen in this X-ray. Quick, this is a spotter.
Transarticular C1, C2 fixation.
Very good. With some.
With
interspinous wiring.
Laminar wiring, yes. Spinous wiring.
Gowtham, again, can you tell one advantage and one disadvantage of this method of fixation as compared to Goel's method?
Sir, one disadvantage is the.
What's advantage?
Okay. Advantage is the. There is no need to dissect the ganglion or the.
Very good, very good, very good. Now, disadvantage.
Disadvantage is technically more complex, sir. And sometimes achieving good stabilization on both sides is usually difficult, sir, in case of gross CVG abnormalities.
Very good. You're telling it. I think you're just short of using the right word. The right word is that pathology has to be reducible. It has to be reducible. Yes. If it is not reducible or irreducible, then it's difficult. And as you told, the right advantage, that minimal dissection is required.
Yes, sir.
So my next question is to Dr. Pratik. Which part of C1 anterior tubercle should you target when you're putting the screw in fluoroscopy to prevent injury to the vertebral artery? You know, C1, you see that on the X-ray, you see the anterior tubercle, and so which part of the tubercle you should target? Now I won't give you much time.
Anterior tubercle, sir.
Which part of anterior tubercle? Of course, anterior tubercle.
Most superior.
I have just one question after this. That's all. Okay, Kartik.
At the inferior most point of the anterior tubercle.
So that is the mistake. Okay, so as I'll show you in this figure here, if you target the inferior point, you have high chance of entering the vertebral artery groove here. Okay, if you stay towards the upper 1/3 or upper half of the C1 anterior arch, you would be slightly, so you have a lesser chance of injuring the vertebral artery here. Okay, so upper 1/3 or upper half is the better or right answer. Okay, now Dr. Gowtham, what screw? Just name the screw.
Lag screw, sir.
Very good. Now there are two mechanisms by which lag screw can work, and can you tell me this first mechanism?
The first mechanism is that the lag screw, it will approximate the distracted bony segments, sir.
It will.
It will approximate. It will approximate the.
How does it approximate? I want to know the mechanism. There are two mechanisms.
Okay, okay, sir. Once the screw passes the proximal segment and enters the distal segment, the proximal segment is unthreaded, so it is loose.
Yes.
So as we tighten the distal segment, the edge of the screw, it will slowly it will bring both the bony edges together.
Yeah, you're almost correct. It's not tightening that this screw will not come, but when you this head touches this proximal fragment, and it has more purchase here. So when you keep tightening it, this will move towards this.
Yes.
Now, Pratik, can you tell there's another mechanism by which this screw can work? And just to give you a clue, this is a fully threaded screw. How can you use a fully threaded screw to produce the lag effect? This is the last question. This is a different mechanism. Kartik? So it's very simple. You have slightly over drilled the proximal part. So again, it becomes slightly loose as we saw here. Okay. So we have already discussed the answer. So thank you very much. You all have done a good job, and all the best to you, and do a good job. Thank you, sir. My job is over.
Thank you, Nupur. And then before we close, like to request Dr. give few advice for the students. We'll have another similar thing on August 15th before the exam on I think the exam is on August 21st, so we'll have another one session on 15th, and from next month onwards we'll have once a month, and we'll alternate month we'll have case discussion and OSCE pattern exams. So I request Dr. Kumar to tell a few words for the advice for the students who are exam going.
Manas,
Kumar, you're online. Yes.
Are you able to hear me now?
Yeah, I can hear you.
Manas, I really enjoyed this session very much. First of all, I have to congratulate all the 4 faculty members. Their preparation was wonderful. It was not only exam oriented, but very practical. It will be very useful to the candidates when they go out and practice. They have shown that they are excellent teachers. My congratulations to all the 4 faculty members. And I'm really happy to see such high quality teaching that is available now. And by and large, the residents also did fairly well. I was closely listening to the answers. It's good. It's a really good session. Very nice practical as well as exam oriented session. Good. Keep it up. Suresh, you want to say something? Suresh Nair?
Thank you, sir. Yeah, very well prepared. And actually, we had a session few days back where all the questions were discussed and slight modifications were made from all the 4 examiners. So that helped a lot. But what I will do, like what I did for the last time, I will just evaluate all these things, and then I will intimate all the examiners what extra one should have asked or what one didn't ask. That I will do. And as Muthukumar was telling, it is an excellent session. All the examiners prepared it so well. And but it's my job to go through all the questions, and if there are any shortcomings in any question, I will just tell in next time what they should ask extra. Okay.
I'd like to thank Professor Nair for spending such time. For the last 2 times, he's been spending time how to modify the question, and he gives a feedback to all the faculty. So that has been quite helpful in selecting the faculty.
I think,
and I hope he continues to do that.
Suresh,
so we are very thankful to Professor Nair, sir, who made the presentations of ours very crisp by modifying the questions in a very optimal manner, sir. Thank you very much, sir.
That's a very good thing.
Yes.
Very well presented, and I was really happy to see the quality of the questions, and the students also, they answered by and large all the questions well. And I hope we had more time to discuss, but beyond 2 hours, it's a little difficult to maintain the concentration. So good work, all the faculty members and residents, and great job as usual by Manas and Suresh. Thank you so much.
Thank you, Manas, sir. Thank you so much.
Before you leave, there's a request that to Dr. Rajeev and Dr. Kuntal, they had some unfinished questions. just project the question so that it will be recorded in the YouTube, so that they can see that later in YouTube, because it is available in YouTube in public. If they just type Examinoline, that will open. So I request Kuntal to just project the questions and the answers also, so that will be recorded in the YouTube. And then Rajeev. Kuntal, you have some few slides. Can you share your screen and finish
Yes,
up
sir.
the...
Yes, sir.
Yeah.
Sir, can you hear me?
Yeah, I can hear you.
Sir, I have 3 questions left actually. So this is one
just,
specimen I wanted to show them, and I wanted them to describe
have to ask anything. Just project it so that it will be recorded.
Yes, sir. Yes, sir.
So
this was a specimen containing one intra-axial lesion here.
Can you share your screen? Yeah.
So can you see?
Yeah.
Fine. Then I just wanted to know 2 differential diagnoses, which can give a picture like this. And usually a question of this sort is asked in the exams. Since it is a post-mortem specimen, so how did this patient die? So the students are required to know the various kinds of brain herniations, supratentorial, infratentorial, central versus lateral herniation. So please do read up. Then I wanted to ask this question as well. This was a case of insular glioma. So my basic concern was to know from them the typical semiology of insular seizures. This is kind of different than the other seizures that we clinically see, although not all the times you will have typical seizures. And the second question that I wanted to ask was to have them identify the deficit that this girl is having. You can clearly see there is a right human kind of facial palsy and right pronated rib. So probably some kind of corticospinal involvement was done by this tumor preoperatively. And most importantly, in a tumor like this, when we are operating, we'd like to ensure safety. And since it is a left-sided insular glioma, language preservation would be as important as motor preservation. So the adjuncts that would be necessary here would be a combination of awake craniotomy, if your institution or if your anesthesia team can provide you that. And of course, a combination of monitoring that will allow you to assess the motor tracts at the cortical level as well as the subcortical level. And the last question that I had was a patient who presented with headache and drowsiness along with congruous homonymous hemianopia. My idea of asking this question was to know from the students whether they can localize a lesion in the optic pathway and how do they differentiate congruous homonymous hemianopia on the basis of optokinetic nystagmus. And they should also know which way the drum or the tape should move if they want to examine a particular hemisphere. And particularly, I would want them to know this rule that is there, that whenever a patient with homonymous hemianopia presents to you, always look for OKN. After you have proven that this is a congruous type of homonymous hemianopia, once you know that this is congruous, it means it is at the level of optic radiation or the occipital cortex. Now you need to see the optokinetic nystagmus. If optokinetic nystagmus is gone, then the lesion has to be a tumor and the lesion has to be a deep parietal or parieto-temporal occipital lesion. On the other hand, if OKN is present, then the lesion has to be in the occipital lobe, and occipital lesions are almost always vascular lesions. So this is a rule of thumb, a clinical rule that you must all know, and it will help you in differentially diagnosing such clinical dilemmas. So thank you, sir. This is what I had, and I must thank everyone for giving this opportunity. Thank you. I hope this was useful.
Yeah. Thanks, Kuntal.
I can just add, is it just clinically, instead of this, if you have a vertical sloping edge and a vertical edge, hemianopia, if you have a vertical edge, it is suggestive of vascular. If you have a sloping edge, it is suggestive of tumor. Other thing is hemianopia, if you lose everything, all colors you lose, it is vascular. Then in compressive lesion, there is a gradation in which so you can clinically without doing okay, no. Yeah. There are other ways also. Anyway, very good.
Rajeev, can you please share off your leftover questions?
Is my screen visible, sir?
Yeah. I've got a slide.
This is the seventh question. This 40-year-old man presented with gradually progressive painless bilateral vision loss over last 3 years. Current vision was 6/60. Fundus showed primary optic atrophy. His hormonal workup was normal, and I have provided CT and MRI images. And first of all, they have to diagnose what is the likely diagnosis of this lesion, and then they have to discuss the management plan of this lesion and what are the likely complications. This lesion is hypo on T1, hyper on T2, inverting on flare, and only this peripheral remanagement. There is small nodule-like thing here, and there is no obvious calcification on CT. Only peripheral enhancement. This lesion is Rathe's cleft cyst, and this needs to be this is derived from the remnant of craniopharyngeal duct, and this needs to be excised by bilateral endoscopic transfrontal approach, and this needs to be marsupialized. Total excision of cyst leads to high incidence of panhypopituitarism and handling of pituitary stalk, leading to permanent DI. Incomplete excision of the cyst is often associated with chances of recurrence and CSF leak. This is the subclassification of cellular Rathke's cleft cyst into cellular, into cellular or cellular with supracellular extension or purely supracellular Rathke's cleft cyst. Coming to the next question, this 13-year-old girl presented with sudden onset severe holocranial headache 2 months back, along with hemiplegia on left side. Over last 2 months, her hemiplegia had remained the same, but headache had subsided completely. I have given them the CT images and MRI images, and followed by DSA. And the CT, they have to interpret this as small calcification, and this will give them a hint that there might be either a neoplasm or there is some vascular lesion. And this MRI is showing a AVM, tuft of vessels surfacing, and it's there in the region of motor cortex. This is a eloquent cortex AVM. Then they have to classify the grade this AVM, and this is the grading. Combined grading is 3/10. Special Martin and Lawton Young grading is 3/10, and out of the 3 options, surgery is the best option for this patient because that will give an opportunity to evacuate the hematoma as hemiplegia is persisting. And this is the surgical process where the large craniotomy is made, and AVM was excised completely. And why not this patient was treated by EMBO? Because EMBO carries a long-term poor occlusion rate, around 35 to 40% at 5 years. GK carries a delayed response, and also doesn't offer the chance of evacuating the hematoma. With surgery, this patient follow-up improved to 3/5 on left side power, and post-op DSA, which is a must in all cases of AVM excision, showed a complete excision of AVM. Coming to the last question, this 3-year-old child presented with the progressive macrocrania for a 3 months old child, for which he was shunted at the age of 3 months. After the shunt, child macrocrania subsided, but over last 12 months following shunt, there was a swelling in the occipital region extending into the neck, and this was slowly progressive with time. There was no history of any fever or any septic signs. I would like them to plan, first of all, identify what is the likely cause of this swelling, and then how to manage it, and if why this complication happened, how it can be prevented in the future. The 2 possibilities are either the shunt is blocked or there is a pericatheter leak from the ventricle, and that is happening, and these 2 can be differentiated by doing a CT scan. As this is the pre-op CT scan, and this is the pre-op CT scan, and this is the post-op scan showing a reduction in ventricle size. Most probably this shunt is at least partially working. Either there is a partial block, or there is a pericatheter leak which is happening in this patient. We can infection can be ruled out by tapping the swelling and draining the CSF, because there is a possibility of subgaleal shunt that might be working, and that is what preventing the progression of ventricle size. in the same tap we can even drain the we can take a CSF sample from the chamber and check the cell count and rule out infection. Once we are sure that we are not dealing with infection and we diagnose it as a case of pericatheter leak, we can revise the shunt, and in the next shunt, instead of doing occipital shunt, we can preferably do the frontal shunt. And this complication can be prevented by making a very small puncture in the dura, and cortical puncture also should be as small as possible to avoid any pericatheter leak. I've done with it, sir. Hello.
You're done.
Sir,
Okay.
yes, sir.
Thank you.
I've done with it, sir.
Manas, can I?
Yes.
This is a suggestion to both you and to Dr. Suresh. Where if in future, for as many questions as possible, wherever feasible, the faculty should also tell the residents the importance of knowing the answer. For example, the IFOF question, the question regarding IFOF, I don't know who presented that. The candidate should know, it's not just the neurology part we need to know, but we need to know about the awake craniotomy and its use during subcortical mapping. So if you just add on a few points like that, the candidates will know the importance why as a neurosurgeon they should know that. Suresh, you have something?
Yeah.
Actually, I wanted them to ask that question. For epilepsy surgery, I was just asking, you have various approaches. One approach is through you go from the inferior limiting sulcus of the insula. So there, how much incision you make when you get IFOF, or you can go through amygdala itself. So we wanted to ask, probably that question it didn't include. We wanted to ask a clinical implication also. Okay, we will do that, no problem. Okay.
So I'd like to thank all faculty, Kuntal, Rajeev, and Bhaskar and Nupur for spending time, because people in this kind of program, they are very hesitant to accept as a faculty because it involves a lot of homework. So I'd like to thank all of you for spending time, and Professor Nair for being all the time with us, and Dr. Muthu Kumar for all the time giving the logistics support from NSI, and all the residents who are eager to participate. And next time also, already we have 4 students who have already confirmed their berths for the program. But special thanks to Mr. Sriram from Icon Life Science, who organizes and helps everybody individually, and then organizes their trial run whenever they want in their convenient time. Is Mr. Sriram there? I'd like to thank especially Mr. Sriram, who does customized care for everybody. With these few words, I'd like to leave. We'll close the session. And
Saudi Arabian colleague, you should especially thank him for coming to this program. Please.
Sir?
Our Saudi Arabian colleague, you thank
Dr. Wael, Saleh, so you can tell your friends also if they're interested, they can write to us, we'll include them.
Yes, sure, Dr. Manas. Thank you very much for you all. Thank you.
Thanks for participating.
Thank you.
Thank you, sir.
So have a nice weekend. Okay.
Okay.
Stay away from COVID.
Good night, and we'll see you again after 2 weeks on August 15th.
Okay. Okay, bye. Good night. Bye.
Good night, sir.